Hello, everyone. Welcome back to another day of our review here. We are on day 51 out of the 90 days of our review sessions. And for those who are new to the channel, you are welcome to stay with us throughout the session today. And we are inviting you to enroll to our NCLEX program. Our course is available. So kindly check out the website at www.stancoastnclexcoaching.com. Again, we're doing our live reviews every day at 9 p.m. Eastern Standard Time. All right. Again, I repeat, we are doing the reviews every day at 9 p.m. Eastern Standard Time, and you're welcome to join with us all throughout the free review sessions. And we are going to tackle a variety of nursing topics. For this time, we're actually focusing on medical surgical nursing, focus on neurology, and we have also updated our library of our resources at our website. So we have upgraded the number of hours of the lectures, and we have the 3,000 NCLEX style questions on top of 200 NG test questions. And our goal really is to boost your confidence with our offerings. Now, we also encourage you to like and subscribe the channel and also this video if you find this helpful. Kindly hit the like button and also share this to your friends who are also reviewing the NCLEX. And again, if you want to send us any questions specific to a topic, then kindly put it in the comment section in the video, not in the live chat, because this is really not going to stay longer. And so I suggest that you put in your comments or questions in the section below. And we always value your feedback and also your thoughts regarding our review sessions. Now, today we'll be talking about the GBS, which is basically the Guillain-Barré Syndrome. And this is another problem in the nervous system, which is basically gonna also involve demyelination. All right, please take note about the GBS. And also, again, it's going to involve demyelination. And this is caused by the immune mediated disease that will occur whenever there is an infection, and the body's immune system will now mistakenly attack the peripheral nerves after an infection. Again, take note about the immune system attacking mistakenly the peripheral nerves after an infection. Now, this is going to lead to a nerve damage, and also it will affect the transmission of the nerve signals. And again, the immune response will usually start with the infection. For those who just join us with all those regular attendees, welcome back to our class today. Let's move forward. Now, when a person gets an infection, especially a respiratory or gastrointestinal infections, their immune system will produce the antibodies to fight the infection. And this is going to cause this cross reaction with the specific components of the nerve cells called the gangliosides. All right. Again, in some cases, these antibodies can cross-react with those specific components of the nerve cells. We call them as the gangliosides. And the gangliosides are found in the surface of the nerve cells, and they are important for the nerve function. Take note of the word gangliosides. They are found on the surface of the cell of the nerve cells or the neurons that are quite important for the nerve function. Now, let's take a look into some common infections that may precipitate the occurrence of the Guillain-Barré. Well, some of these infections we call as the Campylobacter jejuni. This is a specific bacterial infection that can cause diarrhea, and it will have the antigens that can provoke, and they're going to resemble those gangliosides. Okay, antigen in the C. jejuni, they resemble as the gangliocytes. Now, with that resemblance, the body, the immune system, will now attack those gangliocytes. Now, when this process is going to happen, this is what we call as the molecular mimicry. Basically, that antigen with that resemblance to the gangliocytes, again, the body will mistakenly attack the nerve cell. Now, what do you think would be the pathological findings here? Or let me just erase this real quick. The pathological findings in the GBS will mostly occur with like inflammation, wherein those immune cells will infiltrate into the nerve cells. Again, this is going to infiltrate the peripheral nerves. This is with the process of the demyelination, quite similar to the multiple sclerosis, but here it's attacking more on the peripheral nerves. Now, when these immune cells attack, particularly the protective covering called the myelin, then this is going to lead to this condition as the demyelination. Again, the immune cells or the lymphocytes attacking those peripheral nerves will lead to the demyelination, which can now disrupt the nerve's ability to transmit those signals efficiently and will now cause the weakness of the muscles and also the paralysis. And we are not just talking about the skeletal muscle paralysis, but it can also paralyze the respiratory muscles as well. And this is going to be the highlight in a patient with Guillain-Barré syndrome. That is the worst complication that can occur in the Guillain-Barré syndrome. Acute, there is going to be respiratory failure. Now, the damage in the peripheral nerves can really cause a wide range of manifestations. It could range from, let's say, mild muscle weakness, or it could lead to some severe paralysis as well. So here, focusing on the damage, it is actually targeting into the axon. And the nerve damage here will actually go beyond demyelination. And so remember about that analogy that I gave you with the multiple sclerosis. When there is demyelination, there is peeling of that protective rubber for that phone charger cord. Now, the damage actually extends beyond the demyelination. It will also affect the nerve fibers, the axonal damage. So please take note of that. Now let's talk about the remyelination. Is this possible in the GBS? Yes, there will be some recovery. Many people with a Guillain-Barré syndrome can experience some degree of recovery. Even though the nerves have been damaged, the myelin sheath will try to rebuild. Okay, they will try to remyelinate. However, though, the recovery can vary widely among patients, and some may experience some residual nerve damage. And so, yeah, again, the recovery will vary from one person to the next. So don't forget about our concept in a GBS. This is really important. The disease process starts with an infection, and now the body will cause the immune system to develop those antibodies and will attack the peripheral nerves. All right, let's move forward into our discussion with the different subtypes of Guillain-Barré. There are many, not just one. So this is something that you need to really know about the different kinds or types in order that we will be able to intervene properly and also to make appropriate decisions before we're going to make that phone call to the medical provider. And so here we go. We'll start with the acute inflammatory demyelinating polyneuropathy, and we'll just shorten that as AIDP. Okay. Now, The acute inflammatory demyelinating polyneuropathy is the most common form of the Guillain-Barré syndrome in the US. It is the most common. Now, what is going on in this type of GBS? Well, basically, it will involve the widespread demyelination of the peripheral nerves because of the immune-mediated inflammation. And this is going to be caused by the bacterial infection. And we had mentioned that one, that is a Campylobacter jejuni. Okay. Campylobacter jejuni, and this is going to cause a progressive muscle weakness and also sensory abnormalities. Let me clear that one. It can lead to muscle weakness and also some impairment in the sensation. So how is this going to be diagnosed? Well, the patient will be having the CSF analysis through the lumbar tap diagnostic test. So what do you think are those? One is the cerebrospinal fluid analysis, and this is going to show an elevation of the protein, elevated protein in the CSF rather, elevated protein in the CSF. This is what we call as the albuminocytologic dissociation. Again, elevated proteins in the CSF will help in the diagnosis of AIDP. Another testing, yes, viral infection is one. Another is the bacterial infection. There are several causes, not just viral. There are many. That's why we are trying to classify here. Now, we have also identified the EMG. There are many, so hang tight. This is what we call as the electromyography, and this is going to show demyelination of the peripheral nerve. We're talking about the different subtypes here, guys, so pay attention. Now, let's talk about another type of the GBS. This is what we call as the AMAN, or the acute motor axonal neuropathy. And this is going to be seen more in children and also young adults, particularly in the rural areas in the US. Basically, we're referring all these types, of course, mostly occurring in the US, right? And the pathophysiology with AMAN, it can also cause severe damage to the nerve axons. Now, loner alley, as I have said earlier, the bacterial infection has the highest incidence. I mean, it has the highest incidence of the infection compared to the viral. Okay, so I'm discussing here about the bacterial infection with the AIDP. All right, so let's talk about the AMAN. Again, this is going to cause more problems in the young adults and children, and will also cause problem into the nerve axons, which are the long parts of the nerves that will transmit the signals. Remember about those axons? Those very long parts of the neuron, kind of extended. And this is really the target area about this type of GBS. And this is also associated with the C. jejuni infection as well. All right. And this can cause the buildup of the specific antibodies, wherein the person will end up with the muscle weakness affecting the respiratory muscles. Again, this is acute motor axonal neuropathy. Just the name itself. This will give you a clue what really is going to happen. Again, this is rapid onset of muscle weakness, including the respiratory muscles. So how is this going to be diagnosed? Well, same thing with the EMG. This will also cause, this will show the evidence of axonal damage. Those peripheral sections of the neuron. Now, there's going to be blood tests as well that will help out in diagnosing this AMAN. There will be high titers of anti-ganglioside antibodies. High, elevated titers of anti-ganglioside antibodies. And we are talking about the blood test. As we're talking about the prognosis here, or the recovery of this patient with the AMAN, the recovery is thought to be generally good, although it can vary in the patient population. And we'll talk about another subtype here, which is the Miller-Fisher syndrome, which is the MFS. And this is a rare type of a GBS, and it has a triad of symptoms. What are the symptoms that will be more evident in this type of GBS? Well, the person will end up with the ataxia. There is poor coordination of their movement. There's also areflexia, wherein there is loss of those reflexes that are supposedly going to be elicited if we're going to stimulate them, but they are going to be diminished or absent. And the person will have what we call as ophthalmoplegia. There will be eye muscle weakness. Okay. Now, what is really going on with the Miller-Fisher syndrome? This is the development of the antibodies against the specific ganglioside called the GQ1B. This is the type of the antibody that will be detected, okay, in this type of GBS. Now, we're going to have to really pay attention to the clinical examination of this patient, especially with the neurological finding involving the eye muscle weakness. And as far as the prognosis of the Miller-Fisher syndrome, this is much more of, actually, they have better prognosis. Now, let's talk about another subtype here, which is the AMSAN, or the acute motor sensory axonal neuropathy. So involving motor function and also the sensory function. Now, this is similar to the AMAN, but more affecting the sensory nerves. And so this can also affect the person's upper and lower extremities. And the impairment here is much more severe, especially with motor function in the upper and lower extremities. And again, this is going to follow with that infection, the C. And the mechanism here is also going to involve degeneration of the axons and the demyelination, but is thought to be minimal. But again here, the axon is greatly affected, okay, more than the demyelination. Now, how is this going to be tested? Well, the test will be about the EMG. What does it show? Well, it will also show severe axonal damage. And then the blood test for this type, it will also show the anti-ganglioside antibodies. Anti-ganglioside antibodies. And with the recovery of this type, the AMSAN recovery, it is considered to be generally poorer than the AMAN type because of the extensive axonal loss. Poor recovery. Now, let's talk about another subtype here, which is the acute panautonomic neuropathy. What is this type? This is also a rare type of the GBS, which is also going to affect the autonomic system. Autonomic nervous system. So here, the patient will manifest more of problems, especially with the blood pressure. They can be either hypertensive or maybe hypotensive, and it can also affect the bowel and bladder dysfunction. Okay, please take note about the panautonomic activity or the neuropathy, this can cause more of the changes, rapid changes, irregularity in the bladder and bowel control, and also the blood pressure, and also the heart rate. It can range from, let's say, bradycardia or tachycardia. So it is going to manifest those autonomic malfunction. Okay, please take note of that. So how is this going to be detected? Well, the patient here will be tested with their heart rate, of course, not just the blood pressure. It could be high heart rate, or it could be bradycardia. So there's going to be testing of the heart rate variability. It will measure the incidence of the variation in the heart intervals. And the patient will need to have bladder function test. Another is sympathetic skin response, wherein it can detect the activity through the skin conductance. And the disease process is also going to be checked through the CSF, wherein this can also detect the elevation of the protein. Okay, elevated protein, which is the hallmark of the GBS and all the other variants. So again, please take note, guys. The CSF is going to reveal proteins, and it is going to be elevated, not just in the acute panautonomic, but also with the other types of GBS. Now let's talk about the other one, which is the pure sensory GBS. This is going to be much more of a rapid onset of sensory symptoms. Okay, so the patient here will also be checked off with their CSF. It will also reveal the increasing protein level in the cerebrospinal fluid, and also with the EMG, it can also show demyelination in the peripheral nerves. All right, now we're not done yet here. We have another one subtype, which is the pharyngeal cervical brachial variant. And this is going to specifically cause more problems in the face and also the upper limbs. Take note of the name, pharyngeal cervical brachial variant. So this will focus more on its targets towards the upper part of the body, the face, the upper extremities. And this will not affect the lower limbs at all. Okay. Now, the same with the ADP. The manifestations here, or the disease process, can also be tested through the EMG as well. The same thing. Okay. EMG in the cerebrospinal fluid, and it will detect elevation of the protein as well. So please take note about the different subtypes. Let's move forward to a test question right now. Let's see if you have some retention of the concept in GBS, especially what you have encountered in the past. So let's have question 1. A 42-year-old male was recently diagnosed with Guillain-Barré Syndrome, and he presented to the ED with progressive weakness and tingling in his legs, which ascended to his upper body over the past few days. Upon further exam or assessment, the patient exhibits difficulty breathing and decreased reflexes. His vital signs have fluctuated significantly, raising concerns about potential autonomic nervous system involvement. Based on the patient's condition, which autonomic nervous system symptoms may be present in Guillain-Barré syndrome? Select all that apply. Okay, let me eliminate this one instead. So the question will start with the word which autonomic nervous system. Let me just indicate it right there. Let me remove that. We are on page 999. Hang on a sec. Which autonomic nervous system symptoms? So that is going to be more specific. Yeah, go back to that. What is going on? What is going on? Why is it not showing up into my screen? Huh. Wait a minute. I'm not quite sure what's going on with. Anyhow, so the question is, which autonomic nervous system symptoms may be present in Guillain-Barré syndrome? Select all that apply. Is it A, bradycardia, B, tachycardia, hypertension, hyperthermia, hypotension, hyperglycemia, urinary retention, increased salivation? So which one would that be? Or which of these manifestations? This is a select all that apply question. This is asking you about the general autonomic nervous system symptoms. Actually, let me remove that one. Erase. Which autonomic nervous system symptoms may be present in Guillain-Barré syndrome? Select all that apply. So we are seeing ACEG from James, AEG, age. Okay, so this is a general question. It's not really pointing out into the patient in the scenario. This is asking all the autonomic nervous system symptoms. So let's try to filter all these answers here, guys. Let's have bradycardia. What is bradycardia? Which is basically the low heart rate, right? And this is also going to happen into this patient with a GBS. Again, this can cause malfunction in its system. It can lead to the bradycardia. As we know that the autonomic nerves can control the heart rate, and this can be affected as well. And so the person will have the bradycardia. So this is one of the answers. The same thing with the tachycardia. This is also going to be a common symptom in a GBS, wherein the autonomic nervous system cannot properly regulate the heart rate, and they can end up with rapid heart rate. Okay? So hypertension. What about hyperthermia? Do you think hyperthermia will be part of the GBS? Hyperthermia, letter D. Well, the elevation of the temperature is not typically associated with the GBS, as we know that the peripheral nervous system is mainly affected by the GBS and not the central mechanisms controlling the body temperature. Okay, not affected. No temperature effect. Again, it doesn't cause an impairment into the central mechanisms controlling the body temperature. So this is going to be X. What about letter E? Hypotension, low blood pressure. Is this going to be part of the autonomic nervous system malfunction? Yes, this is another symptom of the GBS, wherein the autonomic nervous system can have poor control into the blood pressure. So either hypertension or hypotension. It can also be common in this patient because of the ANS malfunction or dysfunction. Now let's talk about urinary retention. Is this part of it? Urinary retention. Well, we know that the bladder is actually controlled, right? Also the bowel. It can also be affected by the ANS and will affect the patient through urinary retention. Okay, so they will have trouble emptying their bladder. Urinary retention is another one. What about hyperglycemia? Oops, I skipped the hyperglycemia. Is hyperglycemia a manifestation in the GBS? Is it part of the autonomic nervous system? The high blood sugar is not a common autonomic nervous system symptom. It is not directly linked to the dysfunction, especially in the GBS. No link at all. No link with GBS. So this is going to be wrong. This is correct. This is correct. Urinary retention is 1. What about the increased salivation? Is there increasing salivation in the GBS? It is not typical manifestation of the GBS because the GBS, or let's say the autonomic nervous system, will have more effect into the cardiovascular and the GI tract, but not really the salivary glands. Now, we are going to eliminate this one. Now, let's talk about other autonomic manifestations. What are those? Let's talk about the sweating. Well, another effect would be a possibility that there is going to be absence of sweating, which is the anhidrosis. Or the other one, which is the diaphoresis. So both can be present in a patient with the GBS. Now, why is there an absence or reduction in the production of sweat? Why? Well, as we know that the GBS can attack the peripheral nerves, which actually include the autonomic nerves that control the sweat glands. And the damage here can really impair the ability to sweat in certain areas like this one. Now, the opposite, which is the diaphoresis, can also occur. They can have excessive sweating, and this is brought about by the dysfunction in the ANS as well, wherein the production of the sweat is much more of erratic because of the partial damage, or let's say overactive production of sweat because of the peripheral nerve damage. And this is also a body's regulatory mechanism for the sweating. And again, it will be unbalanced this time. Now, another manifestation that is common, talking about the ANS, or not just, yeah, the ANS, is the facial flushing. Please take note of that. And this is caused by the vasodilation, of course. And as we know that the ANS can also regulate the blood vessel tone. And when there is a damage, this can also cause those episodes of flushing. All right, so please take note of these manifestations, especially the autonomic nervous system malfunction. Now let's have question number 2. A nurse is performing a critical assessment of a patient with GBS, focusing on cranial nerve malfunction. Which assessment findings are indicative of cranial nerve involvement in GBS? Select all that apply. Congratulations, Chica, and for those who had got more correct answers. Very good. The question stated, a nurse is performing a critical assessment of a patient with a GBS, focusing on cranial nerve malfunction. Which assessment findings are indicative of cranial nerve involvement in GBS? Select all that apply. Is it loss of gag reflex? B, hearing loss? C, difficulty swallowing? D, blurred vision? E, facial droop? F, tinnitus, ringing in the ears? G, facial weakness? And H, altered sense of smell. Carefully select your answers here, please. We are being asked here about assessing of the cranial nerve malfunction. So what are those assessment findings that you might see in this patient? So This is a select all that apply. Is it loss of gag reflex, hearing loss, difficulty swallowing, blurred vision, facial droop, tinnitus, facial weakness, altered sense of smell? Now let me try eliminating some of the answers here. Let me start with letter H. What is in letter H? Altered sense of smell. So it could be anosmia, a lack of sense of smell. But do you think that this is a common manifestation? No. It is not a typical symptoms of GBS because the olfactory nerve is not involved in the disease. Olfactory nerve, which is the cranial nerve number 1, it's not involved, not affected in GBS. So we are eliminating this one. Altered sense of smell is not correct. Eliminating that one. What about facial weakness? You think facial weakness will be there? Facial weakness or facial, yes. Do you think that there is facial weakness? Well, facial weakness is going to indicate the involvement of cranial nerve number 7, which is also going to be affected in GBS. Cranial nerve number 7, the facial nerve. So when you're going to look into the patient's face, there will be some weakness when they're going to smile, when you're going to ask them to smile and have them show their teeth. There will be weakness. They cannot really, that particular side of the face will not be able to do that extensive smiling, right? There is less movement of that facial muscle, okay? So this is going to be a manifestation in GBS, facial weakness. What about tinnitus or ringing in the ears? Will this be affected by the GBS? Well, it is not affected because the GBS is not associated with the auditory nerves. It's not, okay? We're going to mark this one, not involved in GBS. Whoops. Now let's talk about the facial droop. Well, here we go. That's actually part of it. This is quite similar to the facial weakness. Yeah, facial droop. Even just without asking the patient to smile, you can detect the facial symmetry is not there anymore. The one side of the face could really mimic Bell's palsy. Okay, so when this is involved, especially the facial nerve, cranial nerve number 7 as well. Yeah, it can affect the symmetry of the face. What about blurred vision? Do you think blurred vision is part of it? You think so? Well, in the GBS, it's not a common manifestation. And as we know that the GBS will primarily affect the motor rather than the sensory functions of the cranial nerve. So it's not really going to be a common manifestation. So we are eliminating this one. Let's talk about letter C, difficulty swallowing. Difficulty swallowing. Do you think that this is going to be part of it? Difficulty swallowing or dysphagia is a sign of cranial nerve involvement in GBS. So this is another correct answer. Cranial nerve, this is going to affect the cranial nerve number 9 and also cranial nerve number 10. The glossopharyngeal and also the vagus nerve. So our patient will have difficulty swallowing once these two are involved. Now let's talk about hearing loss. Did we mention anything about hearing loss earlier? Which is basically not a primary manifestation, or it's not really associated with the GBS, not associated. Okay. Marking that as X. What about loss of gag reflex? You think there will be loss of gag reflex here in the GBS? Yes, of course. There is involvement of cranial nerves number 9 and 10. Okay, so we have the following answers. We have letter A, we have letter C, we have E, there's facial weakness. Okay, please take note of those. All right, A, C, E, G are the manifestations of the cranial nerve involved. We have cranial nerve number 9, number 10, number 7. So think about those. All right, please don't forget. Let's talk about the assessment findings of the GBS. All right, so before a GBS can occur, what usually can happen is that the patient will have a preliminary event, which is what we call as antecedent event. What is this? This is going to be preceded by an infection, maybe viral illness, or it could be that bacterial infection. Okay. Now, after that, the patient here will have the muscle weakness. So remember about the pathophysiology that I had mentioned about the development of the antibodies attacking the axon, or let's say the peripheral nerves. Remember about that? And so this can lead to the muscle weakness. All right. So don't forget about the antecedent event, which is basically the infection. All right. So let's talk about the viral illness. Lone Alley, this was the thing that you mentioned earlier. So typical would be the viral, or it could be the bacterial infection. But most often, it has a higher incidence with the C. jejuni. All right. So most of the time, when this patient gets the infection, especially the viral type, this can occur about 2 weeks before onset of symptoms. 2 weeks. So please take note about the development before the GBS happens. Now, with the infection, this can actually trigger the immune response. It can lead to the immune system. It will attack its own peripheral nerves in the body. Now, as we know that there's going to be the immune-mediated disease, it will target the peripheral nerves. And about 2/3 of the patient will actually report bacterial infection or viral infection. Viral or bacterial infection before the onset of neurosymptoms. Before onset of GBS symptoms. And if we're talking about viral type of infection, this is usually preceded by the respiratory type of infection. As we are talking about viral this time. So most of the time it will be caused by a viral type of infection. Could be the COVID, or it could be other, maybe flu as well. And it can also be followed by the GI infections. Now, another event that you should know about will be vaccinations can also lead to the GBS. Okay, let's talk about the vaccinations. Recently, there is a study about the increase of the GBS, especially with the J&J COVID vaccine. Have you known about that? It's actually one of the reasons why people are developing the GBS in the recent times. Don't forget about this. J&J COVID-19 vaccine. And this was way back in July 2021 when the FDA actually announced the potential increased risk of the GBS with the Janssen COVID-19 vaccine. And the risk is higher in men compared to women, and particularly affecting age 50 and above. Okay. Another is the other infection. It could be the Epstein-Barr virus or the Mycoplasma pneumonia, or it could be the varicella zoster virus. So let me just put it here, Epstein-Barr virus, COVID-19 infection. Vaccination, we have a J&J, and we don't know yet with the other vaccines. There's ongoing studies as far as with the association of the GBS with the others. Zika virus is another one. Also, let me just put it right here, Zika virus. And the varicella as well. Okay, so these are your viral infections that can lead to the GBS. Now let's talk about the diminished reflexes. What do you think about the patient having the diminished reflexes? Well, the patient here actually will have much more lesser response when you're eliciting the reflexes, when you're doing the deep tendon reflexes. So you will notice this kind of assessment finding in this patient. All right. Now, as we are going to go along here with the assessment, there's also going to be worsening of the paralysis. There will be tetraplegia, which is the paralysis of the four limbs in severe cases of the GBS. Tetraplegia. It can progress to this worst type of paralysis. And again, this is caused by the progression of the demyelination, which actually will have much broader range of muscle weakness and paralysis. Again, we're talking about the four limbs. Now, another is the neuromuscular respiratory failure, as we are going to be concerned about the respiratory muscle function. And if there is demyelination of the nerves that control the diaphragm, then what do you expect? Also, the intercostal muscles. This can lead to the respiratory failure. Again, if there is demyelination to these areas. Now, let's talk about sensory changes. What are these changes that a GBS person might experience? Well, one of those will be the development of the pins and needles. These are very uncomfortable sensations, the tingling sensation. And these are going to affect in the hands and the feet. And some patients will also complain with numbness, lack of sensation. And this will also precede the weakness, okay? Again, the sensory changes can precede the body weakness. I should have put it right next to the antecedent. Okay, can precede the body weakness or the muscle weakness. And the sensory changes here will often start in the toes and the fingertips. And they might progress. This might go upwards into the wrist or maybe the ankles as well. So not just the toes, fingertips, but this can also go upward beyond those areas, the wrist, ankles. Okay. Now, why is this going on? Why are there any sensory changes? Well, go back to the pathophysiology. There is demyelination affecting the sensory nerves, which is going to cause them to have a loss of sense of vibration. They will also have a loss of sense of touch, and they will also have pain in the distal parts of the body. And the pain here can vary from being mild to severe type of pain. Now let's look at another manifestation here. Pain in the lower back. Lower back pain, or could be the pain in the legs. What do you think about this? Well, again, if there is extensive effect of the demyelination, well, it can cause this severe type of pain. Also caused by the inflammation of the sensory fibers, which can really cause significant discomfort. Now, where are we going to locate these pain? Not just the back and legs. This is very vague. Well, some cases it can involve the shoulder girdle or the shoulder blades. Could also affect the buttocks area. Could be the thighs. And the pain that they're going to complain here is more going to be of achy, throbbing type of pain, even with the slightest movements. So don't ignore this. This is actually part of the issue a patient will encounter. Now let's talk about the cranial nerve involvement. What is going to happen here in this patient? About 45 to 75% of the patients with the GBS will complain the manifestations, and this is caused by the problems in the following cranial nerves. We have the 3, the 7, 9, 10, and 12. I forgot to mention this in the previous slide. And the patient here, of course, with the facial nerve, right? They have that mimicking type of Bell's palsy. There's also double vision, but it's somewhat rare. Cranial nerve number 3, diplopia, is rare. Okay. We have cranial nerve number 7, that weakness, drooping of the face. We also have cranial nerve number 9, number 10, and number 12. And most often here, guys, are going to have issues with their swallowing. Okay. Now, part of the manifestation here, again, with the cranial nerve effect, it's because of the demyelination of the nerve fibers, and they're going to have to display all these deficits. And in the case of the Miller-Fisher, the type of GBS, this type will manifest the cranial nerve deficits first, which is kind of unique. Cranial nerve deficits will show up before anything else. Okay. Now, let's also talk about the bulbar muscle weakness. So what is this? This is basically just generalized muscle weakness of the face and also the throat. And this can really cause impairment in their swallowing and clearing of the secretions. Okay. But this is going to be in the later stage. It's not really about the excessive salivation. It's just the function. Their swallowing ability, they cannot really control it. They will not be able to swallow it safely. And so this is going to be a concern. Airway patency is going to be a problem here. Now, talking about the autonomic nervous system malfunction, this can lead to the cardiac dysrhythmias, either elevated or decreased heart rate, high blood pressure, or hypotension. Again, this is the dysregulation of the autonomic nervous system and able to really manage or control the vital signs. So when the patient gets up, they can potentially fall because of the orthostatic hypotension. And we know that there is also the involvement of the cranial nerve, what? Number 10, which is the vagus nerve. Remember? Yeah. This is also going to be affected. And it will no longer be able to regulate the heart rate and the blood pressure because of the demyelination as well. Now, we're also going to talk about the optic nerve, which I actually mentioned earlier, which is a rare case. not really often, but rare, but it has appeared in some GBS patients. Also thought to be caused by the demyelination. This can lead to the blindness as well. Now let's talk about the symmetric weakness. What do you think about the symmetric weakness? This is going to affect both sides of the body equally. And again, this is going to affect more of the lower extremities, starting with the lower extremities, and it will ascend. Remember about the GBS that it can start from the lower part of the body, and the paralysis will go upwards. Now let's talk about the lung function, vital capacity, and negative inspiratory force changes. So what are these? Well, definitely we need to make sure we are monitoring our patient in order to detect any worsening of their lung function, which can detect impending respiratory failure. Now, what is the vital capacity? The vital capacity and the negative inspiratory force are going to measure the lung function. And if there's going to be a decline in the function of the respiratory muscles, this can really signal that there is much lesser respiratory support. It can progress into the respiratory failure. And lastly, we have urinary retention. This is going to be very difficult for the patient, especially that they're not going to be able to empty their bladder voluntarily. And again, it is caused by the ANS dysfunction. All right, so take note of the assessment findings. There is that preliminary infection before anything can happen. It will progress to the muscle weakness, altered sensation, the reflexes will be diminished. Maybe it can progress to a much severe form, which is the paralysis of the limbs, or it could be respiratory failure. There's also pain sensation because of the demyelination of the nerve sensation, sensory fibers. Also, the autonomic nervous system malfunction. It can cause problems with the heart rate, blood pressure, and also affecting the eyes. Also, the lung function is significantly affected. Same thing with the bladder. And of course, don't forget about the cranial nerves as well, especially the swallowing, difficulty of swallowing, and poor control of the salivation. Now let's talk about the complications here really quick. Well, these are the 4 complications. We have the respiratory failure, the cardiac dysrhythmia is caused by the dysregulation of the autonomic nervous system, and also because of the paralysis. Our patient will develop those complications caused by the immobility. They are not going to be able to really sense the amount of pressure. Remember that their alteration in the sensation plus decrease in the mobility can really lead them to developing the other complications such as the DVT, the PE, urinary retention, and also the skin breakdown. Now, not just physical manifestation or complication, this can also affect the patient's overall mental state. They can get really anxious because they really don't know. They're not sure what's really going to happen to them. And of course, depression can also set in. Now, let's talk about, guys, with question number 3. A nurse is assessing a patient suspected of having GBS. Which diagnostic tests are typically used to confirm the diagnosis? Select all that apply. A, complete blood count. B, electromyography or EMG. C, nerve conduction studies, or known as the NCS. D, liver function test. E, lumbar puncture for CSF analysis. F, chest x-ray. G, pulmonary function test. H, magnetic resonance imaging. So you have 1, 2, 3, 4, 5, 6, 7, 8 choices for this select all that apply. Take your pick. While you're doing that, I'm going to start answering these. So let me start with, okay, ACEG. Okay. Let's talk about magnetic resonance imaging. Do you think that MRI will detect the GBS? Okay. Magnetic resonance imaging, the MRI. We know that the MRI can help exclude other conditions, right, that might mimic the GBS, such as the mechanical causes of myelopathy. But the MRI is not a specific diagnostic tool in diagnosing GBS, okay? It can only exclude other conditions that might mimic GBS, but not specific, okay? Not a specific diagnostic tool. Can only exclude other condition. Can exclude other condition. But as far as diagnosing GBS, no, it doesn't have that capability. It is more use of a differential diagnosis. This is what we call as differential diagnosis of other disorders, right? But not really on the GBS. It doesn't confirm the GBS. So we are eliminating that one. What about letter G? Pulmonary function tests. Pulmonary function test. There are several tests that's actually involved in the PFTs. There are so many, guys, so please don't neglect this because this is often asked in NCLEX, especially with the COPD, emphysema, bronchitis, and this is also used in the neurological disorders, especially with the GBS. So don't forget about the pulmonary function test. You really need to engage yourself. Go back to the concept about the pulmonary function test. So the PFTs is just the cluster, right? This is composed of several testing. PFTs, pulmonary function test. They're going to be very crucial in monitoring the respiratory status of our GBS patient. If there is going to be weakening of the respiratory muscles, yeah, they are going to really determine that, yeah, this patient is probably going to progress into the failure in the next few hours because of the abnormal results. So let's talk about one of the most common tests involved in the pulmonary function test, which is the forced vital capacity. Forced vital capacity, FVC. What do you think about this FVC? Well, normally it is known that the normal value is generally about 80 to 120%. Normal value is about 80 to 120% of the predicted value. And I've mentioned this in the lecture, especially in the respiratory system. So go back to that topic. The FVC, the forced vital capacity, is the total amount of air that a person can forcibly exhale after a full inhalation. Again, this is the measurement of the total amount of air that can be forcibly exhaled by the patient after they have a full inhalation. Okay, so the FVC can assess the lung capacity and also the respiratory muscle strength. However, in the GBS, there is going to be reduced FVC. The FVC rather, they're not going to be able to forcefully exhale the amount of air that they had inhaled. Okay, please take note of that. There will be less forced vital capacity in this patient. They cannot forcefully exhale the amount of air that they inhaled because of the weakening respiratory muscle. Weak respiratory muscle. Now, another is the NIF. This is going to be a little bit lengthy, guys, so hang tight. This is what we call as the negative inspiratory pressure. So pay attention. Do not neglect this. Maybe some other reviewers will be like, yeah, it's not going to come out, but yeah, what do you think if it will come out in the exam? You should be ready, guys. So the normal value here is actually more negative than 60, which is kind of odd. I actually included this in the respiratory discussion. It is normally going to be more than negative 60 cm water, and that is going to be the reference value, more negative than negative 60. So the negative inspiratory pressure, just the word itself, negative inspiratory pressure. Let me erase this one right here so I'll have more room. The NIF basically can measure the maximal pressure that can be generated by the inspiratory muscles, especially the diaphragm, when you are asking the patient to forcefully inhale. So the NIF will measure the maximal pressure that is going to be generated by the diaphragm when you're asking the patient to forcefully inhale. That's why it's called negative inspiratory pressure. So if the patient cannot really take in that much of air when they're told to inhale forcefully, then there is something wrong with the strength of their muscles. So that simply means that they have less negative value. So there is also going to be, in GBS, less force of inhalation. So please take note of that. In Guillain-Barré Syndrome, the patient will have much less force during their inhalation. They cannot do a lot of the inhalation, guys. So take note of that. That's the NIF. Let's talk about another one, which is the maximum expiratory pressure. All right, MEP. Maximum expiratory pressure. You really need to pay attention to the words in the terms here. Expiratory pressure. So the normal value here will be greater than 80 centimeters of water. Normal value greater than 80 cm water for men. This is for the men. However, in women, it will be greater than 70 cm water. Okay, females. So what does the maximum expiratory pressure entail? Well, this is going to measure the maximal pressure that will be generated by the expiratory muscle when you are going to instruct the patient to forcefully exhale. Again, the maximum expiratory pressure is the amount of pressure that can be produced by the expiratory muscles when they are instructed to expire forcefully. Again, this will check the integrity, the strength of the expiratory muscles. Assesses the strength of expiratory muscles. So when they are instructed rather to exhale forcefully, this value will be much lowered. Remember, our reference value for men is more than 80 cm water and more than 70 cm water for female. However, if there is GBS, the values will be much lower. All right, we're not done yet. Let's talk about number 4. Let me put it right up here. I hope that you're writing down notes because I'm trying to simplify these things, because when you're reading them in the nursing books, it sounds so, what is this? They don't even explain this much. PEF, which is the peak expiratory flow, PEF. All right, peak expiratory flow. So what is this? The value normally here is around 400 to 600 liters per minute. Take a look. PEF has a normal value of about 400 to 600 liters per minute in healthy adults. Now, what does the PEF measure? Well, it can measure the highest speed wherein the air can be expelled from the lungs. Again, this is the peak expiratory flow, which will detect the highest speed wherein the air can be expelled from the lungs. So here, the patient is tested on their ability to expel the air quickly. And this value can be significantly reduced in the GBS as well. Reduced in GBS. Again, this is going to test the strength of the expiratory muscles in a patient with the GBS. All right. Now, moving forward into another testing, tidal volume. I'm running out of space. Tidal volume. The TV. This is approximately about 500 mLs. And what is the TV? This basically is going to measure the amount of air that the person inhales or exhales during a normal breath. So just regular breathing pattern. And so the amount is about 500 mLs that can be inhaled or exhaled. And so it definitely will indicate the amount of air moved out with each breath. And this is going to be significantly decreased in the GBS as well. Decreased in GBS. All right, please don't forget all these: pulmonary function test, forced vital capacity, NIF, maximum expiratory pressure, and we also have the the PF and the tidal volume. Please do not forget these things. Now let me erase this. We are going to finish off with our rationalization. MRI is going to be removed. We have the pulmonary function test, which is going to be very critical assessment or evaluation in a patient with a GBS. All right. Critical assessment in GBS. Now let's talk about letter F, chest x-ray. Do you think that chest x-ray can help out in diagnosing the GBS? It's not. This can be performed though if the medical provider is suspecting maybe for any respiratory complications, maybe pneumonia, but this does not provide information specific to the GBS. Okay. Only detects complications in GBS, especially respi function, but not the GBS itself. Now let's talk about letter E, the lumbar puncture for analysis. Remember what I said earlier during our first test question? CSF, lumbar puncture. Okay, what do you think about that? Lumbar puncture for CSF analysis is another correct answer. Remember that there is going to be an elevation of what? The protein levels in the CSF. Elevation of protein in the CSF. Again, this is what we call as the albuminocytologic dissociation. Elevation of protein in the CSF. Now, let's have letter D, liver function test, the LFTs. Do you think that this is going to be part of the diagnostic test? LFTs? Yeah? No? LFTs are not going to be relevant in the diagnosis of the GBS. It's specific to check the liver alone, okay? But not neuro and immunological processes in GBS. All right, marking this one. What about letter C? Nerve conduction studies, NCS. Remember I said something about the NCS earlier? This can detect the specific abnormalities wherein there is going to be delayed distal latency. There's going to be slowing down of the conduction of the nerve impulses. Slowed conduction of nerve impulses, especially in the peripheral parts of the body. Okay? There will be conduction blocks because of what? The demyelination. Remember? Yeah. The demyelination can lead to a slower conduction of those nerve impulses. So that's part of the test, NCS. What about the electromyography? Well, I've already mentioned that earlier, right? The EMG will also evaluate the nerve function, and it can detect the demyelination. It can also detect the less firing, or there is rapid firing in the weak muscles, but there is decreased motor unit recruitment. Okay, and it can also detect the axonal degeneration, as we have spoke earlier. So this is also part of it. Now, A, complete blood count. Do you think that the CBC will help diagnose the patient with a GBS? No. It will only be used as one of the preliminary tests to identify possible problems, maybe, if there is association with other infections, but it doesn't really gonna specify, or it doesn't really rule out the, I'm sorry, it can rule out other conditions, but it doesn't provide specific diagnostic information regarding the GBS. So we are eliminating that one. So our answers here are the following. Why is my pen just doing crazy stuff? Answers are, we have letter B, we have letter C, lumbar, which is letter E, and the pulmonary function test, B, C, E, G. Okay, we're gonna have to eliminate the CBC because the CBC is, most often it will show normal results in the GBS, as we know that the infection is actually going to happen earlier. It doesn't happen during the disease itself, the disease process. So it's not going to reliably detect the occurrence of the GBS. It will only detect if there is an infection going on, but not the disease process itself. All right, let's move forward to number 4. A nursing student is asked by the nurse about the treatment of Guillain-Barré Syndrome during the acute period. Which statements made by the nursing student are correct? Select all that apply. A, corticosteroids are commonly used to reduce the severity of GBS. B, plasma exchange is one of the treatments used to reduce the immune-related nerve damage in GBS. C, intravenous immunoglobulin therapy is less effective than plasma exchange for treating GBS. D, patients with GBS are often admitted to the intensive care unit to monitor for complications. E, mechanical ventilation is rarely needed for GBS patients since respiratory failure is uncommon. And letter F, supportive care is not necessary for GBS patients once they receive plasma exchange or IVIG. Take your selections for a select all the apply question. What do you think, guys, are the correct statements? What are these statements? All right, before I'm gonna have to deal with the correct statements, let me eliminate the incorrect statements this time. So if the student stated corticosteroids are commonly used to reduce the severity of GBS, this is wrong. Incorrect. Why? There is no evidence of the corticosteroid treating a patient with the GBS. They have been tested in several clinical trials, but have not been found to be effective. So it doesn't reduce the severity of the GBS. Okay, according to the clinical trials, not found to be effective. Okay, so we are eliminating letter A. No corticosteroids, but the corticosteroids can be used in the patient with myasthenia gravis. Remember, right? Our lecture yesterday about the myasthenia gravis. It's going to work in that kind of problem, which is caused by an autoimmune, but not this one, not this kind of issue. It's been tested in the clinical trials, but never been found to really reduce the severity. So it's not advised, and I've seen that in the medicine textbooks. They're putting in there no corticosteroids. And wherever you're going to look up, maybe in the NIH, or maybe if you're going to look it up in the CDC website, corticosteroids are not going to be used in the GBS. They're not effective. Let's talk about intravenous immunoglobulin therapy. IVIG is less effective than plasma exchange for treating GBS. So that would be letter C. What do you think about this? Intravenous immunoglobulin therapy is less effective than plasma exchange. This is not true. This is incorrect. Well, why? The IVIG is actually going to be beneficial. They are both equally effective if started within 2 weeks of the symptoms, the onset of the symptoms, okay? So the correct rationale for this is both are effective if started within 2 weeks of symptom onset. Or I'll just put that as onset. 2 weeks, within 2 weeks of symptom onset. Onset of, let me reword that. 2 weeks of symptom onset. All right, so not true, not less effective. Both are going to be effective equally. Now let's have another false statement here. And what would be that statement? That is, the supportive care is not necessary for GBS patients once they receive plasma exchange or IVIG. Well, it's not true as well. They would still need the supportive care. We are going to treat our patients symptomatically. So this is not true. Not necessary is wrong. The supportive care here will include managing the monitoring the patient's respiratory function. We also need to manage those manifestations, the autonomic manifestation. So especially with the signs of respiratory involvement, we need to deal with that, the dysphagia. What else? We need to also treat the patient's bowel and bladder malfunction. Remember about the autonomic malfunction with the ANS? Yeah. The difficulty of swallowing, the urinary retention, the bowel issue, respiratory involvement. Yes, they definitely need to continue to get the supportive care, even if they receive the plasma exchange or the IVIG. It doesn't mean that once they get these two that we no longer give them those. No, that's incorrect. Now this time we'll talk about the correct manifestation, or the correct statement. So yeah, you'll see already those correct answers, right? So let's start with letter B. Plasma exchange is one of the treatments used to reduce the immune-related nerve damage in GBS. That is 100% correct. It is one of the main treatments used in the GBS, and the reason that this is effective because it can reduce immune related nerve damage. So it will be helpful in removing the harmful antibodies. Okay, removes antibodies. Remember about the plasmapheresis, the patient will be having that session similar to the dialysis. They're going to have this 3 to 5 times in a week period. The patient's blood will be filtered and those antibodies will be removed, and the patient will have a replacement of those albumin instead. Okay, so again, the patient's blood is being cleansed. Now, so that's correct. What about letter D? Patients with GBS are often admitted to the intensive care to monitor for complications. Exactly, because the complexity in the care of this patient, especially with the respiratory function, this will require one-to-one care. This is something that med-surg nurses cannot manage, all right, because of the complexity of the disease process. It's not that the nurses don't have the skill really, but the ratio, it's just not safe to leave this patient in the med-surg unit, especially if there is no involvement of the respiratory function. If there is progression of the respiratory manifestations, we're not going to keep this patient in med-surg. Ship them out to the ICU for close monitoring. Okay, this is true. Letter E, MEC ventilation is rarely needed for GBS patients since respiratory failure is uncommon. That is incorrect. It's not uncommon. It is common. And that is why mechanical ventilation would be the potential treatment in our patient, because eventually they're going to end up with respiratory failure if the symptoms are quite severe. So our correct answers here are letters. Letter B. What else? We have letter D and letter E. All right, I hope that you're learning here with the test questions. I hope that you are. Let's talk about number 5. Which assessment finding in a patient? Before I go to do that, again, I'm inviting everyone, if you haven't enrolled yet, to our NCLEX course, please visit Stancoast nclexcoaching.com and also visit the link below in our description box so you will know more about us. And we also have upgraded our library of on-demand videos and also the animated videos plus the NGN test questions and also the 3,000 NCLEX questions. We have them available for you, and please do so. Thanks. Now let's talk about number 5. Which assessment finding in a patient with Guillain-Barré Syndrome requires the nurse's immediate action? Let me go back into letter E. Yeah, that's true. E is incorrect. All right, going back to number 5. Which assessment finding in a patient with Guillain-Barré Syndrome requires the nurse's immediate action? Is it A, the patient has reddened skin in the sacral area? B, the patient is continuously drooling saliva? C, the patient complains of severe pain in the feet? Please, if respiratory failure is common, how can be rarely used? Let's go back to that. I'm sorry. Mechanical ventilation is actually rarely used. Oh, so this is a incorrect answer. So our patient, the correct answers here are letters B and D. Plasma exchange. Patients with GBS are often admitted because rarely used. No, this is wrong. So statements, okay. So we only have letters B, D, not E. Sorry about that error. Okay, correcting number 4, guys. Letter E is going to be eliminated. Yeah, I made a mistake there with tagging. Yeah, I already put here common, so that was the clue that it is incorrect. So the correct answers here are only B and D. Okay, again, correcting item number 4. Our correct answers are only letters B and D, no letter E. This is incorrect. Thank you for figuring that out, Boss Babe. Okay, wonderful. Let's have number 5. So the options are: the patient has reddened skin in the sacral area. B, the patient is continuously drooling saliva. C, the patient complains of severe pain in the feet. And D, patient's blood pressure is 148/85 mmHg. What will be your answer here? Guillain-Barré Syndrome requires nurses' immediate action. We are worried about something that could potentially cause a problem in their oxygenation or their breathing or their airway. So what would be that one? So the correct answer for this test item is letter B. The patient is continuously drooling saliva. That is the correct answer. Remember that with the dysphagia, the involvement of those cranial nerves, the 9, 10, and the 12, they will not be able to manage their oral secretions. And of course, they will tend to collect those saliva in their mouth. The patient that is continuously drooling will indicate that they have impairment in their swallowing. So they are at risk to aspirate. Aspiration risk. Okay. So again, with the problems with the cranial nerves, 9 and also the 10 and the 12, they are in high aspiration risk. It can lead to respiratory compromise and can also lead to the pneumonia. So our action here would be to deal with this patient in letter B. Okay? Now, what about letter D or letter C? Patient complains of severe pain in the feet. Yeah, this is something that we need to address as well in the patient with the peripheral neuropathy as a manifestation of the GBS, but it doesn't show a higher critical value compared to the letter B with the aspiration risk. Okay? Can be addressed after dealing with option B. Okay. So eliminating letter C. Patient's blood pressure is 148/85. It is high, but does it look urgent? It doesn't really show some kind of a urgency or emergency. So we're going to definitely monitor this patient. Do not neglect requires monitoring. Okay, remember about the autonomic nervous system malfunction or dysfunction? Yeah, we have to monitor, do not neglect, but it's not as critical compared to letter B. Letter A, patient has reddened skin in the sacral area. It is also important, but doesn't take higher priority compared to letter B. We know that they can really be prone to having the skin break down, but it's not gonna call for a more immediate nursing action. So our correct answer here is letter B. All righty. Number 6. A 45-year-old male patient newly diagnosed with Guillain-Barré Syndrome experiences numbness and weakness in both feet. The nurse anticipates teaching the patient about A, immunoglobulin infusions, B, intubation and mechanical ventilation procedures, C, corticosteroid during corticosteroid drug administration, and D, insertion of a nasogastric feeding tube. The nurse anticipates teaching the patient about, remember about Guillain-Barré. What would you include in the teaching, or what would be your primary education point for this patient with a diagnosis of the GBS? Are we going to teach them the corticosteroid? Remember that the corticosteroids are not effective. We are eliminating letter C right away. We already talked about this one. No, did not show. Effectiveness in clinical trials. So corticosteroids are going to be, it's going to be eliminated. All right. This is not recommended anymore in the GBS. It used to be, but not anymore. You probably will see this in the old med-surg books in nursing. You probably will see the corticosteroids in the old books, but not in the recent practice. Not applicable. Let's talk about insertion of the NG tube. What is in there? Well, the insertion of nasogastric tube is going to be needed when there is going to have dysphagia. This is going to be a treatment if the patient will be having severe dysphagia, indicated for severe dysphagia, but not an immediate priority in the patient that has been newly diagnosed. We're talking about a patient that is newly diagnosed with Guillain-Barré and with experience with manifestations of numbness and weakness of both feet. So our patient is probably considered as in the milder state. They're not having the swallowing difficulty this time yet, so this will not be required, okay, around this time. It will be required in the later time. Let's talk about letter A, IV immunoglobulin infusion. What do you think about that? This is going to be the appropriate treatment for the patient, especially in the early stages of the GBS, in order to reduce the severity. It will also reduce the symptoms, okay? This is indicated. Remember about the administration. It should be done within the 2-week period after the onset of the GBS symptoms, indicated in the early stages of GBS. Now, the reason for that is to decrease the severity and also decrease the duration of symptoms. Decreases severity, and also it will decrease the duration. No sound. Do I have sound? That's kind of weird. Anita, are you okay? I haven't heard anybody complaining, or I haven't seen any complaints about the audio. So kindly check your device. So this is going to be the correct answer. Anticipate teaching the patient about IV immunoglobulin infusion. Letter B, intubation and mechanical ventilation procedures. This is going to be anticipated when there is now involvement of the respiratory muscles, but not during the earlier stage of the GBS. Appropriate when there is respiratory muscle involvement. Okay. So we are being asked about teaching. What would be that teaching point that is appropriate for this nurse to include or to impart into the patient who has a new diagnosis of the GBS? All right. So don't neglect to read the statement or the scenario carefully. All right. So find the appropriate topic that should be tackled during this phase of the GBS. All right. Thank you. Number 7. As part of the initial assessment for a 55-year-old male patient newly admitted, the nurse identifies the most critical aspect to monitor. What crucial nursing assessment should the nurse prioritize? Is it A, patient's level of alertness, B, strength of the arms and legs, C, rate and effort of breathing, D, rhythm and rate of the heart? The statement is, as part of the initial assessment for a 55-year-old male patient newly admitted, the nurse identifies the most critical aspect to monitor. So let me actually, the statement was cut off here. This is admitted with a diagnosis of Guillain-Barré, number 1007. Let me just correct that. 1007. With a GBS. Okay. So I hope that clarifies that. Okay. As part of the initial assessment for a 55-year-old male patient newly admitted with GBS, the nurse identifies the most critical aspect to monitor. What crucial nursing assessment should the nurse prioritize? Okay. Is it A, B, C, D? Okay, I'm seeing letter C. That's a good indicator. Again, our patient's respiratory function is of higher priority this time. The most critical aspect to monitor. It doesn't mean that their new admission that you're not gonna anticipate about assessing or monitoring their lung function. Yes, you do. Okay? It's not going to be neglected this time. You have to. All right? If the situation only stated about newly admitted patient with GBS, no other. That's kind of odd. Let me type that here. Are you able to hear me, guys? All right. I hope that she can fix her audio or the speaker, whatever. All right. Yeah. Thank you for checking, because I actually don't have my monitor on because I don't want any feedback on my end. Well, that's a good thing. Okay, so what would be our priority here? Our patient is a new admission with GBS, but we don't know really the severity yet. Okay, severity of GBS is unknown in the scenario. Okay, this is definitely different to the scenario that we just answered in item number 6. But here we are generally just asked about the most critical aspect to monitor. So what would be the crucial aspect? Always think about the airway, the circulation, or the breathing, the circulation. So We don't have any other better choice, or we don't have the best choice, but letter C. We are going to check for the rate and effort of their breathing, as we know that the GBS can happen rapidly, and the respiratory failure is a serious complication of the GBS, and our monitoring here should be started right away as soon the patient is admitted. Okay, so guys, as an add-on to here, as soon as the patient is diagnosed or identified or admitted to the hospital, the monitoring of pulmonary function tests is critical. Okay? Please take note, guys. Yeah, it can happen first in the lower extremities. It has that ascending pattern, but we don't know for sure when exactly that ascending pattern can happen. And so we got to be ready to make sure we are monitoring the patient's lung function. The monitoring of the lung function doesn't happen just once, not just during admission, but this is going to be done daily. In some hospitals, this is going to be done twice a day, even 3 times a day. So it can vary. But again, the monitoring, the pulmonary function test will happen more frequently in order to detect any changes in the respiratory function. This is very critical for you to know. All right. Hey everyone, I'm unstable today. What do you mean unstable, AJ? Is your connection unstable? Now let's talk about alertness, patient's level of alertness. Do you think that this will take higher priority compared to the rate and effort of breathing? No. It is important. Alertness check is important, but it doesn't proceed to dealing with the assessment, especially with the patient's rate and effort of breathing. This is the complication that we really want to avoid. Okay? All right. The patient's level of consciousness will take maybe second priority this time. Okay? Maybe if in a scenario that is different, maybe this is going to affect the patient's LOC with some kind of a severe issue. Maybe the answer here will be different. But for here, we're going to have to prioritize making sure that we are monitoring the patient's effort of breathing. Even though the patient is newly admitted, we don't have any information about the patient's GBS severity. So take a look into the patient's respiratory function. Rhythm and rate of the heart is also important. We're going to have to monitor that because we know that it can be malfunctional because of the ANS effect, cardiac dysrhythmias. But this is less occurring in the patients, all right? It can affect the ANS, but not as bad as this one. With the respiratory strength of the arms and legs, this is also an important assessment, but not going to precede the assessment of our patient's respiratory function. Let's talk about 8. Which assessment data for a patient who has Guillain-Barré syndrome will require the most immediate action? I think we already tackled this one. Let's move forward. Number 9. After the nurse receives the shift verbal report in the med-surg unit, which client? After the nurse receives the shift verbal report in the medical surgical unit, which client should the nurse assess first? Yes. AJ, you can watch the video later. Yeah. So what would be that patient that you should prioritize in assessing first? Is it A, a 20-year-old client 1 day after appendectomy? B, a 36-year-old client recently diagnosed with GBS? C, a 48-year-old client 3 days post-heart attack? D, a 54-year-old client with diverticulitis? Yeah, of course. 9 is letter B. A 36-year-old client with recently diagnosed with the GBS. That is the correct answer. Why? We know that the GBS can rapidly progress. That's the answer. Letter B. Because of rapid progression from the paralysis of the lower extremities or weakness or paralysis of the BLE, and it goes upward. Respiratory impairment. Okay? It can happen rapidly. So we're going to prioritize this patient, make sure that our assessments, monitoring will be done on this patient. Okay? Now, taking a look into letter A, 20-year-old client 1 day after appendectomy. It doesn't really give us any more information if this patient is having any other issues. With this patient, it's not known if they have any respiratory failure or life-threatening complications that will require immediate assessment. It doesn't have that information, so we're gonna place this in the back burner. What about letter C? A 48-year-old client with 3 days post-heart attack. We know that a patient with MI can develop the cardiac dysrhythmias, right? But especially that we don't have the specific information regarding this patient. Do you think that you need to see this patient right away? They are going to be monitored as well, but at this point, the prioritization will fall mostly on the letter B. Okay, this patient in letter C is already being monitored. Okay, monitored and is already undergoing treatment. Already treated. Please like on the main button to help more people to join the class. Yeah, thank you, boss babe. Now, let's take a look onto letter D, diverticulitis. What do you think about the diverticulitis? Do you think that this is priority as well? It will require monitoring as well. Maybe this patient could potentially complicate into the perforation, but with this, just that kind of information, it doesn't really present a more urgent manifestation. There's no reason or evidence that we need to attend to this patient right now. There's no life-threatening manifestations that's being shown in the scenario as well. So we will take a look first our new patient with a GPS because of the rapid progression of their problems. Okay. This can also possible complications, bowel perforation. Those are complications, abscess, infections, right? But again, our information is so limited. But our patient with B would take higher priority, as I've already mentioned. Number 10, a 45-year-old male patient with Guillain-Barré Syndrome has experienced a sharp decline in vital capacity. He presents with increasing weakness and difficulty in breathing. What is the nurse's most appropriate action? Is it A, administer albuterol inhalation as ordered? B, reinforce the importance of deep breathing and coughing exercises to the patient? C, prepare to assist with endotracheal tube placement? And D, administer oxygen via nasal cannula. Very busy night at work. Oh my gosh. Well, get some sleep, chica. Get some sleep. A 45-year-old male patient with GBS has experienced sharp decline. Yeah, that's not a good indication. Vital capacity Remember about the vital capacity that we talked in the previous slide? Our patient's respiratory function is markedly reduced, increasing weakness, difficulty in breathing. Do not delay the treatment of this patient. They can code because of respiratory failure. So you need to do letter C, prepare to assist endotracheal tube placement. The albuterol inhalation, no, it's not going to work. It will only cause the bronchodilation, just the airway. But we are talking about the respiratory muscles. Yeah. Only treats bronchospasm. Cannot treat respiratory muscle paralysis. The concern here is the paralysis of the respiratory muscles, the diaphragm, the intercostal muscles. So we are eliminating letter A. It doesn't work for this patient, okay? It will only cause bronchodilation, but not about treating the paralysis. Let's take a look in letter D. Administer oxygen via nasal cannula. No, it will not treat the patient's impending respiratory failure. Only increasing, or you're only adding the supplement. It will only provide very temporary support, but does not address the respiratory muscle paralysis. Temporary support. But then again, it doesn't address the paralysis. No, it cannot. Here, reinforce the importance of deep breathing and coughing exercises. Yeah, this is a good intervention, but in the moment wherein your patient now has reduced vital capacity, the coughing and deep breathing exercises are not going to address the acute respiratory failure. They're not going to prevent that, okay? Our patient requires immediate intubation, okay? We're going to remove letter B. Sound is not audible. Uh-oh. What is going on with the sound today? Can you please check your audio, guys? Can you please let me know if my audio is not working? My audio is already maximum right now. Okay. Let us talk about number 11. The nurse is preparing care for a patient. The nurse is preparing care for a patient diagnosed with GBS. Considering the typical symptoms of the condition, the nurse should communicate with the patient about the potential occurrences of which sign or symptom of GBS. Okay, let me reread that. I got so distracted right now. The nurse is preparing care for a patient diagnosed with GBS, considering the typical symptoms of the condition. The nurse should communicate with the patient about the potential occurrences or occurrence of which sign or symptom of GBS. Is it occasional hearing loss? B, ringing of the ears? C, enlarged tongue? Or D, paralysis of the vocal cords? James has already answered letter D, which is correct. Okay? So, typical symptoms of the condition. The nurse should communicate with the patient about the potential. So basically, you are alerting your patient this time to have them tell you, hey, if in case you're going to experience this, can you let me know? Okay? So the correct answer here is paralysis of the vocal cords. Remember about the cranial nerve involvement? Yeah. So our priority here is the paralysis of the vocal cords. And what are those cranial nerves involved? Remember, it can involve the vagus nerves, which is basically the innervation on the vocal cords. Okay. Vagus nerve. Okay. And with the vocal cord paralysis, this can lead to hoarseness. Hoarseness. What else? Difficulty speaking. Dysarthria. So these are signs of paralysis of the vocal cords. The patient should notify the nurse know right away whenever they're gonna have these manifestations. Okay. Occasional hearing loss. We already talked about this earlier, that hearing loss is not typical. It's not a manifestation of VGBS. Not a manifestation of GBS. Same thing with the ringing in the ears, tinnitus. No, that's false. And also, hi graciously, how are you? Enlarged tongue. What is enlarged tongue? First, I've seen this one. Enlarged tongue is not typical manifestation of the Guillain-Barré. Okay. Enlargement of the tongue. It could be found in patients with the amyloidosis. Okay. Amyloidosis. Okay. Not about the GBS. Take a look at that one. Our answer is letter D. Vagus nerve involvement. Cranial nerve number. What is it again? Cranial nerve number 10. Let's talk about 12. The nurse is carrying a care plan, or the nurse is creating rather a care plan for a 55-year-old female patient recently diagnosed with GBS. Which intervention should the nurse prioritize for this patient? Is it A, regular use of the incentive spirometer as prescribed? B, ensuring the patient remains in bed? C, providing aids to help with any visual impairment? D, conducting frequent checks for signs of cognitive decline? Hello, Jeanette. Thank you. That's fine. I'm seeing letter A's. D, A, D. Let's try to eliminate first. What would be your priority this time? Recently diagnosed with Guillain-Barré. Alrighty, let me start with something at the bottom. Conducting frequent checks for signs of cognitive decline. Remember, guys, that our GBS is going to affect primarily on the sensory and the motor function. GBS primarily affects motor and sensory function. Okay. So, cognitive decline is not going to be associated with this syndrome. There is no decline. So monitoring the cognitive function of our patient will not be a priority this time. It doesn't cost this one. So we are eliminating that one. The GBS has more effect into the sensory and the motor function. Respiratory muscles, skeletal muscles, sensation, those are the main issues. Mobility, yeah. What about letter C? Providing aids to help with any visual impairment. Will this be a priority action for this patient? Providing aids to help with any visual impairment. Will that take higher priority compared to a much more crucial one? Yeah, it doesn't really primarily affect, though it has some effect, right? With a double vision. But there is one more intervention that will take place, that will take higher priority compared to this one. Okay, so we are eliminating letter C as well. What about B and A? Which one would you choose between the two? Ensuring the patient remains in bed, or are you going to have them to use the incentive spirometer regularly? We know that our patient here is going to be weak, right? They might have some forms of paralysis in the lower extremity, but bed rest, ensuring that the patient remains in bed, unless if it's specifically indicated, there is no need for us to really keep the patient in bed. They could be out on a chair, could be in the wheelchair, but not necessarily in bed. Our goal here is to at least maintain the respiratory function of our patient, have them use the incentive spirometer, okay? Because of the muscle weakness, especially the respiratory muscles, this will help maintain the lung volume. It maintains lung volume and can also prevent atelectasis. So have them do the deep breathing exercises through the incentive spirometer, okay? While the patient is not collapsing yet, or let's say having the respiratory failure, have them constantly use the incentive spirometer regularly on schedule as ordered to make sure that we are preventing atelectasis, because we know that there will be reduction in their lung function. But before the respiratory failure can set in, they need to do this, okay? That's the reason why the incentive spirometer can help them out, the patient rather, in avoiding the atelectasis, okay? We know that we will eventually intubate this patient if our treatment will fail. Maybe they're not really responding to the plasmapheresis or the IVIG. We will have them use the incentive spirometer, but we have to be alert to monitor all the time our patient's respiratory function. Okay. 13, a 60-year-old male patient diagnosed with GBS is being cared for in the ICU. The nurse is prioritizing assessments to manage potential complications associated with the condition. What is the nurse's priority when monitoring for potential complications in this patient? Is it A, monitoring for skin breakdown due to immobility and sensory deficits? B, assessing for changes in cognitive function and mental status? C, watching for signs of bleeding or hemorrhage related to the disease process? And D, prioritizing evaluation of autonomic nervous system dysfunction. Your patient is an older person. Okay. 60-year-old, welcome. Lily, the blessed, the blessed. Okay, welcome to the class. 60-year-old male patient diagnosed with GBS, cared for in the ICU. The nurse is prioritizing assessment to manage potential complications associated with the condition. What is the nurse's priority? You answered letter D. Mariflora answered letter A. Priority. Remember about the autonomic nervous system? What can you recall about the autonomic nervous system dysfunction? Remember that it can affect a wide variety of organs in the body. Remember that it can cause decreased heart rate, or it could increase the heart rate, decrease BP, or increased BP. What else? There is going to be urinary retention, flushing. Yeah. And so comparing your answer from letter D to monitoring skin breakdown, which would take priority this time? I would deal first with letter D. You have to assess, you have to monitor the patient's autonomic nervous system because of the possible cardiac dysrhythmias. Okay? The patient will require continuous cardiac monitoring. And not just that, but also their vital signs. Remember, it can cause the cardiac dysrhythmias. That's why we need to keep an eye on their heart rhythm, also their vital signs because of the hypertensive crisis, or it could be orthostatic hypotension, or the blood pressure, the heart rate as well. Okay, so we are answering letter D this time. This is going to be less crucial. Okay, what about this one? Assessing for changes in cognitive function and mental status. We already talked about this, that the GBS does not primarily affect the patient's cognitive function and also their mental state, eliminating that one. Instead, the GBS can impair motor and sensory function, not mental status. That's wrong. Letter C, watching for signs of bleeding or hemorrhage. We don't know anything about that as part of the GBS disease process. There's nothing about that. It's so unrelated. There's no association about the bleeding and the GBS. There's no predisposition for them to develop bleeding, not associated with GBS, eliminating that one. Okay, so our correct answer here, guys, is on letter D, autonomic dysfunction. Alrighty. Let's have number 14. Before I'm going to proceed again, I am inviting everyone, for those who have not checked out our website, if you can go through that website, check out, and we are also offering that NCLEX course. We have updated our library of on-demand videos, plus the animated videos. We have the extensive library of the lectures, plus the resources that we have, and also the test questions we have are about 3,000 for the NCLEX type, and we also have the 200 NGN test questions. So if you want to know more about us, kindly click the description box below, guys. Number 14, the nurse is educating a 50-year-old male patient with a GBS about the condition. The patient asks about the possibility of nerve recovery despite demyelination. What would be the nurse's most appropriate response to the patient's question? Is it A, Guillain-Barré Syndrome allows for remyelination during the recovery phase due to sparing of the Schwann cells? B, Schwann cells in Guillain-Barré syndrome replicate themselves before being affected, allowing for remyelination. C, nerve cells typically do not undergo remyelination, so your physician can provide more specific information. And letter D, In Guillain-Barré syndrome, activated Schwann cells play a crucial role in initiating the remyelination process. Remember, I mentioned this earlier about the recovery in the disease process. Remember that slide? I mentioned that one. There's going to be remyelination. So let's have the elimination. Letter D. In Guillain-Barré syndrome, activated Schwann cells play a crucial role in initiating the remyelination process. This is wrong. Why? I know that the Schwann cells are going to be involved in the remyelination process, but they are not typically activated in the sense described here. Not Schwann cells are not typically activated. When you hear this, when you're actually reading this one, like in GBS, activated Schwann cells play a crucial role. It seems like something is triggering the Schwann cells, but it doesn't work that way. The recovery of the Schwann cells actually contribute to the remyelination, but they are not activated as a primary response to the GBS. No, there's no such thing as activation. It is going to happen spontaneously. So the word activated Schwann cells make this statement wrong. What about letter C? Nerve cells typically do not undergo remyelination, so your physician can provide more specific information. Do you think that's true? Letter C. Nerve cells do not undergo. That is false. Yes, they do. They can recover. They can do the remyelination. Okay? In the peripheral nerves affected by the GBS, there is going to be remyelination that can occur during the recovery phase. Okay? Remyelination. Okay? This is going to start in the recovery phase. Okay? It is going to be spontaneous remyelination, especially with the Schwann cells. Okay? So the statement here saying, so your physician can provide more specific information, that is wrong. The nurse should know this. They can provide more specific information about the remyelination in this context. So you're just kind of like shoving your patient, blowing off about their query. Okay, so that is wrong. What about letter A? Guillain-Barré syndrome allows for remyelination during the recovery phase due to sparing of the Schwann cells. What do you think about that? This is the correct answer because the GBS primarily affects the peripheral nervous system, and they are going to involve more on the demyelination of the nerve fibers. The Schwann cells here, they're going to produce the myelin in the peripheral nervous system, and they're going to be spared and they will recover during the disease course. This is the correct statement. Okay? So they are basically spared. That is why they are going to regenerate. They're going to assist in fixing the demyelinated fibers. Okay, so this is the correct answers. Letter B. The Schwann cells in GBS replicate themselves before being affected. No, it doesn't have that ability to replicate before the GBS. It is not the mechanism like that kind of statement is not true. The recovery, the remyelination can only happen after the onset of the GBS, during the recovery. Okay, so there's no such thing as replication before the GBS. This is wrong. Okay, so we have a correct answer, letter A. Let's have number 15. What common characteristics do clients with myasthenia gravis, Guillain-Barré syndrome, and amyotrophic lateral sclerosis share? Is it A, gradual decline in health until death occurs? B, deficiency in crucial neurotransmitters? C, heightened susceptibility to respiratory complications? D, involuntary twitching of small muscle groups? What common characteristic do clients with myasthenia gravis, Guillain-Barré syndrome, and amyotrophic lateral sclerosis share? Is it A, apparently with the MS, that is not found to be a mechanism. Okay, it's not known to be, yeah, there's no such thing as the remyelination in MS. It hasn't been found. So only in the GBS. In MS, there's always going to be progression. Okay, but not about the remyelination. It hasn't been known. So in MS, they're going to end up with that progressive chronic demyelination of the nerve fibers. So what is your answer here? You're answering letter C. Okay. Common characteristic in MS and in myasthenia gravis, rather, GBS, and I'm amyotrophic lateral sclerosis. I'm having a GBS today. Just kidding. So letter C is the correct answer. There is going to be a gradual decline. Or also there is heightened susceptibility, rather. There is high susceptibility to the respiratory complications in all three disorders. Remember that with the myasthenia gravis, the respiratory muscles can also be affected. They will have periods of exacerbations, remission. In GBS, they have a massive impact on the respiratory muscles as well. It can require the patient to have mechanical ventilation. And the same thing with ALS. The motor neurons controlling the voluntary muscles can also involve the muscles helping the patient to breathe. Okay, so this is the correct answer. Let's eliminate letter A. Gradual decline in health until death occurs. Is it true in all three? Gradual decline. We know that the ALS can really lead to a much more gradual decline, also death, right? But it's not universally true to MG and the GBS. Not true to GBS and MG. Okay? Not true. So we are eliminating that one. Letter B, deficiency in crucial neurotransmitters. Whoever answered this one, oh, thank goodness. Very good. You answered all C. Deficiency in crucial neurotransmitter. There are no deficiencies in all three. Okay? The myasthenia gravis involves the decrease in the number of the acetylcholine receptor sites. Okay, so let's go back to the myasthenia gravis. There is no decrease in acetylcholine. However, there is decrease in the number of receptor sites, decrease of acetylcholine colon receptor sites, but not about the neurotransmitter. Okay? Now, as we know about the GBS, do we have issues with the neurotransmitter reduced in the GBS? No, we don't have. The same thing with the ALS. So this is going to be eliminated as well. What about letter D? Involuntary twitching of small muscle groups. Do you think that this is common in all three? Involuntary muscle twitching. Well, it is not going to be shared between the myasthenia gravis and GBS and also ALS. It is. Okay? For the myasthenia gravis, there is weakness of the muscles. No twitching. And the same thing with the GBS. There is weakness and paralysis, but no twitching. We don't have that as part of our manifestation. No twitching. And same thing with ALS. There's going to be a weakness and atrophy of the muscles, but no twitching as well. So twitching is not shared on all three. Okay? No twitching. All right, so our correct answer here is only letter C. Let's move forward with number 16. A nurse is attending to a client diagnosed with GBS who is experiencing challenges in clearing respiratory secretions. What action should the nurse prioritize first? Is it A, listen for breath sounds? B, clear the client's throat and mouth using suction? C, provide additional oxygen through nasal cannula? And D, position the client upright. What do you think about this test question? A nurse is attending to a client diagnosed with GBS who is experiencing challenges in clearing. There is problem with, they cannot manage the secretions. So what you should do as the nurse here? No matter what position they're in, they just can't. They can't. The positioning here will probably just help with the drainage, but if they have the if we have that option, look into the options here. Listening to the breath sounds, it will not clear the secretions, right? Immediately remove that. What about letter B? Clear the client's throat and mouth using suction. Which one would do better this time? Would that be position the client upright? Even if you position them upright, it will not be effective in causing or preventing the choking. All right. The problem here is the muscles, the dysphagia. There is not effective management of their salivation because of the difficulty in the swallowing, the cranial nerve involvement, 9, 10, and the 12. It will not be able to function well. So no matter what, if you're just going to put them on one side or upright, it's not going to help really. You need to take on clearing the client's throat and mouth using the suction. That would be the correct answer. I know that you are probably going by the steps in fundamentals of nursing, positioning, something like that. But in our case with the GBS, the positioning will not do a whole lot. Okay? Not a lot. It can probably help some, but here for this patient that has already problems in clearing their secretions, our best answer here is to use that suction tip. Okay? That is a priority. We don't want our patient to aspirate. Yeah, first the word sometimes, but as you are identifying the patient that has GBS, comparing the patient with a GBS, or let's say a patient that has pneumonia that doesn't have any problem in their swallowing, or let's say a patient that has COPD or emphysema. Comparing these three patients, the others don't have problem in the swallowing. So the sitting upright would be more applicable before we can do the suctioning. But here, no, I know the first is confusing, but consider the case, guys. The case of your patient here is on GBS. It will not be applicable to other patients. All right, like I've said, their ability to contain their secretions is no longer there. It's not going to be as effective compared to clearing their secretions right away. If you have a patient that has GBS, don't delay the suctioning. You gotta do it right away. We don't want to cause the aspiration on these patients. All right, enough said. Let's have number 17. A nurse is planning care for a client diagnosed with a GBS. Which nursing intervention is expected for this client? Is it A, offering a straw to stimulate facial muscles for improved oral function? B, adjusting the ventilator settings to assist with breathing? C, promoting gentle exercises to prevent muscle wasting? And D, giving antibiotics to prevent respiratory infections? Which nursing intervention is expected for this patient? Planning care for a client diagnosed with a GBS. Is it A, offering a straw to simulate facial muscles for improved oral function? Or B, adjusting ventilator settings to assist with breathing? C, promoting gentle exercises to prevent muscle wasting? And D, giving antibiotics to prevent respiratory infections? So this is a general question on a patient with a GBS. We don't have adequate information, just mainly asking us what would be that intervention that we should be doing. And you have to pay attention into the what do you call this? Pay attention into the complication as well, or the main feature in the GBS. We don't have anything else, but select on letter B, adjusting ventilator settings to assist with breathing. This is going to be done, especially with a patient that has progressive paralysis. We know that the paralysis starts from the lower extremities, but this can develop rapidly, okay? It can involve the respiratory muscles. It can lead to respiratory failure. If you answered letter A, offering a straw to stimulate facial muscles, will it help? Facial muscles for improved oral function. That technique is not appropriate for a client with a GBS. The patient will have varying degrees of the paralysis, including the facial muscles, okay? So here, remember about the cranial nerve number 7? The straw will not help. It will not be effective, okay, with that paralysis. The patient can also have issue with the swallowing. Remember about cranial nerve number 9, the 10th, and the 12th as well. So our patient definitely has aspiration risk because of the swallowing difficulty, and this can worsen anytime as well. So this is wrong. Promoting gentle exercises, what would that nursing intervention lead to? Well, the patient is known to have progressive paralysis and weakness. So the gentle exercises is going to be not gonna do a whole lot. Muscle wasting, gentle exercises. This is a waste of time. Actually, the patient here would require actually especially during the acute phase, there is going to be progressive muscle weakness and paralysis. So even with the physical activity, this could exacerbate the muscle weakness and fatigue rather than preventing muscle wasting. And the physical therapy can be done, it can be initiated, but it's not going to be as effective up until the patient will have a resolution of their acute manifestations. Okay, it will not be as effective. The gentle exercise will not do any good for this patient. It will not prevent muscle wasting. Letter D, giving antibiotics. They're not known to be given as a prophylaxis for respiratory infections. There is no routine need for this patient to get the prophylactic antibiotics. There is none. If there is going to be an infection, then that's the time that the medical provider will treat or give the orders to treat the respiratory infection, but no prophylaxis. Okay, there's no preventive indication about the antibiotic. Okay, all right, so that's about it for the test question. We're gonna talk about the nursing interventions. We are gonna focus this time about the nursing process. So our goal here with our patient that has the GBS is to maintain respiratory function. That is our primary goal. We need to what? Monitor the patient's respiratory status, the breath sounds, the vital capacity, the NIF. We're going to have to, let me add that right here, vital capacity, and other pulmonary function tests. There are several of those. Do not forget those other pulmonary function tests. We have to monitor for the ascending weakness. And like I've said, this is rapidly progressing. It can happen anytime. We need to monitor this patient. And we have to watch for any respiratory fatigue and also breathlessness. So when you're going to speak to the patient and they're going to be easily fatigued, just like answering your questions, this is a bad sign. Breathlessness while talking is a sign of respiratory fatigue. Another is we're going to have to give them a calm environment, and we're going to have to elevate the head of a bed to maximize their lung expansion. Okay. Lung expansion to prevent atelectasis. Just supportive measures, but it's not going to treat. We're going to have to be cautious in administering the medications. We know that the patient with a GBS, they will have the pain, right? Remember about the peripheral neuropathy? But you got to be cautious in administering those pain medication, especially the opioids, because of possible respiratory depression. Respiratory depression. Got to be careful, guys. So if we have non-narcotic type of medications, if the pain is not that bad, if the pain is mild or moderate, we can probably make use of those non-narcotic or non-opioid medications. We also need to monitor our patients' vital signs, right? Especially the heart rate, the respiratory rate. This is very important, as we know that it can impair the autonomic nervous system. And with elevation of the respiratory rate as well, there is going to be shortness of breath. Remember that this is probably a precursor that our patient is going into a respiratory failure, weakening of the, they're not going to be able to really breathe in and out as the normal people can do. The use of enzyme spirometer is going to maximize the lung function. That's important. Chest physiotherapy is going to be helpful as well if there is consolidation of fluids in order for them to prevent lung collapse. Then definitely we're going to have to incorporate that one as ordered. Now, what else? Possible intubation and mechanical ventilation is something that we should anticipate, especially if there is progressive rapid development of the GBS, you have to be ready for this, okay? And like I've said, you can detect that there is already worsening of the patient's condition by looking into the pulmonary function test. Monitor the readings. Okay, you will see a decline. So if there is consistent decline and if it's getting worse and worse, then our patient needs to be intubated. Okay, now tracheostomy placement would be a long-term management. And so this is something that you should also consider in educating your patient, especially. Okay, tracheostomy placement. Now let's talk about the other nursing interventions. Preventing complications. Now, our patient needs the cardiac monitoring continuously because of the ANS dysfunction. Remember about the cardiac dysrhythmias? Yeah. Cardiac dysrhythmias. And also the vital signs monitoring is very important because of the hypertension. Blood pressure is high. It could be orthostatic as well. So pay attention to that. Patient positioning is also important. I'm talking about regular repositioning because they are prone to skin breakdown. Loss of sensation and also impaired mobility. Not a good combination for this patient. Risk of skin breakdown. So if you're the nurse here, you got to do your Braden scale religiously this time. Make sure that you're going to report any significant points for your patient with a GBS. What else? ROM exercises. This is going to be done as part of the prevention, like DVT prevention. Okay, so if there is the use of, it will also make use of the SCDs. Are you aware about the SCDs, the sequential compression devices? That's going to be part of the care. SCDs, sequential compression device. The ROM exercises here is geared towards the prevention of the DVT and the PE. Not a whole lot more about the atrophy. That can be dealt with as soon as the patient is much more stable. PTOT is going to be another important treatment. This is very important, guys. PTOT. And also we're going to have to check for the patient's muscle. Look for those contractures. Make sure that our patient is positioned properly. Make sure that we have those devices that can prevent the contractures. If it's affecting the heels, we got to make sure that they're wearing those boots to maintain the neutral position of our patient's foot. Also check for the pressure ulcers, edema, and with the constipation is caused by the ANS malfunction. And the use of the assistive devices will be employed as well in order to prevent any injuries. If there's a need for them to use the tripod cane or maybe the walker, then have them use it according to the recommendation by the physical therapist. Rehabilitation is also important in order for our patient to have much more a prolonged recovery. And let's not forget, nutrition is very important. We need to assess our patient's chewing and swallowing abilities. If they're not going to be safely, if they're not safe to do the swallowing or chewing, they will just, hey, I don't want to eat. I'm afraid that I might choke. Make sure that you assess carefully the cranial nerves, right? Those cranial nerves, the 9, 10, and 12, we need to keep an eye on those as well. Possibility our patient might end up with enteral or parenteral nutrition. If the swallowing becomes so severe, the impairment in the swallowing rather, if they have significant dysphagia, then the medical provider can probably order the enteral feeding or parenteral nutrition. Back to the previous slide. Which one? This one? The PTOT, is that what you're asking maybe? The PTOT that we are talking about here will be more of the later. I mean, it can be initiated, but it doesn't really going to be so helpful during the earlier stage. Okay, it can be started. Okay. All right. More of the mobility here is actually geared to preventing the DVT because of the sluggishness in the patient circulation. Okay, not a whole lot on the muscle atrophy. It can be done so much more during the recovery phase, but not during the acute phase. Okay. The prevention here is geared more towards the DVT prevention. Okay, let's talk about frequent small feeding. So for those patients that are still able to swallow safely, if they don't have any significant swallowing difficulty, then in order to maintain their nutrition, then frequent small feedings would be recommended in order to prevent significant negative protein balance. Dietitian referral is also important. Make sure that they're involved in the care, especially with the consistency of the food items. Maybe they're gonna also recalculate those nutrients in the diet. Now, take a look into the maintenance of communication. This is very important, guys, because as we know that our patient's speech will be affected as well. With the paralysis of the vocal cord, the patient will not be able to talk, or maybe they cannot really enunciate the words clearly. So we're going to make sure that they have alternative means of communication for those nonverbal clients. So we want to make sure that they can still talk to us through the nonverbal means. Now, also provide explanations consistently and make sure that we are providing them reassurance that there is a chance that they can recover, not full recover, but they will have a chance to recover. But this will really involve some form of rapport in your patient. You need to establish before the patient can really trust you with all your explanations, right? Another thing is speech therapy, evaluation and treatment. They are very helpful in devising the diet modification of our patient, especially if they already have issues in the swallowing. They can modify the fluid intake. Maybe they're going to make the fluids a little thicker or maybe nectar thick. We don't know, but those are expected. Now, let's also deal with the patient's pain management. This is going to be addressed with the administration of the analgesics. It could be the opioid or the non-opioid or non-steroidal type of medications, but you've got to be cautious, especially with the opioid rather. And aside from administering the opioid products or the NSAIDs, there's also alternative pain management techniques. Many: massage, therapeutic touch, and we're gonna also regularly reposition the patient to prevent those areas that are at risk. Okay, so we are going to relieve the pressure points as well. Frequent repositioning plus the use of air mattress. Air mattress. I actually miss doing this at the bedside. Air mattress, Q2-hour repositioning, Q2-hour skin check. Yeah, especially if the patient is having issue with their bowel or bladder control, we need to check for any possibilities that they might have. Skin breakdown can happen fast. We need to reduce their anxiety and fear, which is very important. especially that this is a very sudden occurrence and a life-threatening as well. We need to build rapport with the patient, establish trust, and we need to address those concerns as well. If they have any questions, then we have to tell them truthful answers, no false reassurance this time. Okay? And again, building rapport is so crucial before we can deal with some more communication here. We're going to have to reassure them that there's a likelihood to recovery, and with the fear that they might get more isolated, they will get lonely, they have that sense of lack of control. So that's part of the fear. And here we as nurses should intervene in order for us to allow the patient to have that kind of a sense of control. We need to give them information about the condition. We need to emphasize positive appraisal or coping resources. We'll also need to teach them about relaxation exercise and relaxation exercises and distraction techniques. So don't forget these. Family is also going to be involved here because they're going to be the main support, especially in this difficult transition. All right, our patient education here, guys, will include the following. We have to let them know that the acute phase will last for about 1 to 4 weeks. And there is that stabilization phase and also rehabilitation and finally the recovery or the convalescence phase that can happen 3 months up to 2 years. So at least they have something to look forward to, that they should, hey, I really want to keep going with my physical therapy because I want to get better with my muscle function. So make sure that they understood the phases of the disease process. They will have chances of recovering. Breathing exercises would be very important with the use of the incentive spirometer to prevent the complications of atelectasis. Supportive shoes is also important, especially at home. Remember that they have the lack of sensation. Supportive shoes is going to be helpful. It will prevent them from having any injuries, especially in the home setting. Routine foot checks, because of the decreased sensation, they might ignore those painful sensation that we usually can feel, right? They don't have that anymore. So they need to frequently check their soles of their feet to see if there's any injury or wounds, and make sure that they're also maintaining a healthy weight. And this is to help reduce the motor strain and also will lessen the fatigue when they're moving up and about. Okay. Now, so that's it about the GBS. So I hope that you're learning something today, and I hope that you are having some more insights as far as going through the test. I know that we are doing a lot of the SATs, but this will help you really identify those erroneous options. Again, do your elimination, please. You really need to master that. Even if you don't really know the disease process, it can help. So again, guys, thank you for your attendance today, and I really appreciate your active participation. And for those new members of the class, we are encouraging you to join us again tomorrow at 9 p.m. and also encouraging you to enroll to our course at Stancoast NCLEXcoaching.com. Please don't forget to hit that like button and subscribe to us if you haven't done that one yet. Okay, share this video to your friends so we will grow in our audience as well. So again, thank you everyone. Appreciate you. I'll see you tomorrow. Goodbye and take care.